Hey, so I wanted to do a video about what are the golden formulas that might be best suited to CT technology, specifically as it relates to the registry, but then things that we need in everyday clinical practice. And this came in part due to a response from the golden formulas worksheet that I did for X-ray technology in the X-ray registry. Angie wrote and said, would you do one of these for CT? And I said, well, what would be the golden formulas? And she identified effective mass, number of photons, window width, window level, spatial resolution, line pairs, and Hounsfield formula. I'm going to do my best to address those things. I'm also going to speak to what you might actually expect to see on the CT registry related to this stuff, because we can go, with CT, we can go to like a depth that's way too much for what we're actually going to be tested on. So I just want to, I'll kind of pull the reins back when I need to. So let's first talk about photon number. So anytime we're messing with mass, we're essentially directing the amount of electrons that are being produced or boiled off by the filament, and that same amount of electrons that then is kind of forming an electron cloud around the filament is what will be accelerated towards the anode in order to produce X-rays. So the number of photons is directly related to the number of electrons that we had to begin with. So using milliamperage, we're essentially boiling off electrons and saying that that's proportional to photon number. So we can say, this is grossly simplifying the process, but we can say that milliamperes per second in essence translates to millicoulomb. So if we have an MA, we can figure out about how many coulombs we're talking about. Where a coulomb, that's not C as in like the constant, like E equals mc squared. This is C for coulomb, which is a measure of electrostatic charges. So in essence, a number of electrons. In fact, 1 coulomb equals 6.25 10 to the 18th electrons. And just to give you a perspective on how many electrons I'm talking about, that number is a quintillion, right? So this is a super huge number. For example, this is roughly the number of ways you could fill out the brackets for the NCAA tournament, right? Or the number of possible solutions to chess, I think. If we say 1 millicoulomb, that equals 6.25 times 10 to the 15th. This is still a very large number. It's a quadrillion, which is roughly the number of ants. Like there's about 1 quadrillion to maybe 10 quadrillion ants on the Earth, right? So, and their biomass is approximately equal to the total biomass of the human race. So I'm just trying to give you some perspective to how large these numbers are. They're huge, right? So what we're doing, you may not realize this when you're activating a CT scanner, but what you're doing is you're exploring a statistical phenomena that's based on quadrillions and even quintillions of interactions. So we can kind of, keeping with this kind of short and simple way, we can simplify it even further to say 100 mass would equal 100 millicoulombs, or 6.25 times 10 to the 18th electrons, and that would be roughly the equivalent to the number of photons that would be produced, 6.25, or I guess 0.625 quintillion X-ray photons. So why don't we go ahead and test ourselves with this knowledge. I am going to be writing very much like my 5-year-old son with this, because I'm using a stylus and it's not my strongest suit. But going back to the original formula, I would write this 6.25 times 40, right? If I multiply those together, that gives me 250, right? And if we're asking like, well, 250 what? Then we don't quite have the whole picture, because it's times 10 to the 15th, but we wouldn't write it this way, right? We would hop the decimal point over 2 and write this as 2.5 times 10 to the 17th X-ray photons. So a very, very large number of X-ray photons. So these are what are incident on the patient, all these X-ray photons. They are attenuated by the patient to differing degrees depending on what area of the body we're scanning with the CT scanner. And then what we're measuring on the exit side is how many of those photons that are incident on the image receptor. And we're basically doing a difference between what we started with and what remained, is the way that I generally talk about this process of attenuation that's occurring inside the patient. Now, we can use the computer to vary the mass according to just how dense the patient is, or different attenuation values that are happening inside of the patient. So what we're talking about when we talk about effective mass is we've got an amount of mass that's required to make this slice, an amount of mass that's required to make, this slice, and I'm drawing these as axial slices, but really this has more to do with helical. So, but just bear with me. I'll draw it as helical. I'll put, this is the wraparound portion right here. Here's another slice, and here's the scanner spinning around, right? And so as we change the pitch, we have to change the mass as well in order to compensate for what's occurring as we change the pitch. So increasing the pitch will have to increase the mass, but this will wind up with roughly the same volumetric dose. The CTDI will remain the same. So to decrease the patient dose, we actually have to decrease the pitch and the true mass. Now this is according to Euclid's theorem, and I would say that this is in all likelihood a point of some controversy, because it would depend on the CT imaging system that we're working with and how it calculates effective mass and how it relates that to pitch, because for the most part, as we're decreasing pitch, we can assume that we would have a slight increase in patient dose due to potential for scan overlap. So I'm saying, in terms of what we need to know about effective mass, just understand that mass is related not just to boiling off electrons and them striking the anode in CT. In the world of CT, it also has to do with how quickly the table's moving through the scanner. They are interrelated. So I wanted to make this as simple as possible. What I think is helpful for us to know for the registry is not these points of controversy, but just how to calculate pitch, and then how to understand a CTDI volumetric. So first off, pitch equals table movement per rotation divided by the beam width per rotation. So beam width is just going to be the slice number times the slice thickness. So if we say that we have a 16 slice CT scan, that would be 16 slices. What is the average slice thickness? Is, just for example, 2.5 millimeters. So we would multiply 16 times 2.5 and we would have the beam width. So again, table movement divided by beam width gives us the pitch, and this is typically used to talk about table movement. So as we increase the pitch, and generally most pitch values are between 1 and 1.5. That's the kind of the golden range of pitch values for CT scanning. If we go much higher than 1.5, we can start to lose information within the volume that we're scanning. We start to get more what we call volume averaging, where we miss things. So if you can imagine on this pitch of 2 here, if the patient had a kidney stone or something right there, we just missed it because we scanned past it. But conversely, if you look at this pitch of 0.5, we've got overlap, and this is what I'm talking about. This would wind up increasing the mass. So this is why I'm saying there's a point of controversy with what Euclid's theorem is saying, is because if I decrease the pitch to 0.5 and I decrease the mass, that doesn't matter. I have just increased the patient dose because I'm over scanning, right? I'm over scanning that area. So we just need to be familiar with what's occurring here, and this would wind up increasing dose because of overscan. So that's what we're trying to express when we talk about CTDI volumetric. So this is a CTDI weighted per each slice divided by the pitch, and this is going to be an expression of the radiation absorbed by the patient's body. It's going to be expressed in gray. I don't necessarily think that we need to calculate a CTDI volumetric to be able to pass the registry exam. I think we're pretty far into the health physics weeds at that point. If we just understand that a volumetric expression of dose will be expressed in gray, and that it's giving us the weighted dose per slice and dividing that by the pitch so it has an idea of how that pitch is influencing patient dose, we are golden. What I do think is going to be helpful for us is to be able to calculate pitch. So of all of these things, right, in terms of effective mass, we need to understand how all these things interrelate critically, but in terms of like what's the actual formula here that's helpful for us to know, it's just pitch. So let's go ahead and work that. So we've got 15 millimeters, and we'll place that on top, And I should point out, pitch is a dimensionless thing, and so we'll talk about how that could be the case here in just a minute. We've got 16 slices. We're going to multiply that by the 0.625. You'll notice almost all these numbers are kind of binary, at least the slice thickness and things like that. So that would be 15 millimeters, pardon my writing, over 10 millimeters. So at this point, the millimeters just canceled, and we have a pitch of 1.5. 1.5 pitch is just the way that that would be expressed. All right, well, here's another really complicated formula that I'm going to do my best to simplify. I really like the very brief discussion about the Hounsfield unit found in one of my favorite books of all time, Radiologic Physics War Machine by Prometheus Lionheart, MD. If you don't have it, I would recommend picking up a copy, particularly for those of you who are tuning into this channel because you're interested in something beyond the Registry for Radiologic Technology, like you're a radiologist or a physicist. I really enjoy that book. It's really funny. So the important thing to understand about this formula is that it's trying to express attenuation values, and it's doing it on a scale of 2000. So, well, where did I get that information from? Well, just notice the water on the bottom and the water on the top. What this is telling us is in this formula, water is our 0 point. So on the Hounsfield scale, everything zeros on water, right? And then we can go 1,000 more than water, but you can also go 1,000 less than water. That's that linear attenuation coefficient for air. And just if you're curious, what do I mean by linear attenuation coefficient? That's this mu. I've just written it really poorly here. But it has to do with attenuation values for different things. So the linear attenuation value of X, like for example, kidneys, right? Or if we want to get even more specific, the linear attenuation value of a nephron, right? That would be linear attenuation value X minus the attenuation value of water over the attenuation value of water minus a very specific measurement of attenuation value in air. So if we have something basically that is less attenuating than water, we would expect it to be negative on the Hounsfield unit scale. And if it's something has a higher attenuation value than water, we would expect it to be positive on the Hounsfield unit scale. So let's look at that real quick. Water, again, is the 0 point. And the easy way that I think about the Hounsfield unit is just anything that floats has a negative Hounsfield unit. So if for some reason patient's lungs go flying out of their body and land in a lake, their lungs are going to float. So guess what? They are negative, right? So we're down here in this area when we're talking about water. Negative Hounsfield units, right? Negative 800 or so, somewhere in there for the lung. So again, water 0 right here. If it's anything that sinks, that would have a positive Hounsfield value. So one of the things that's interesting is look at brain matter. Brain matter has some fat in it, right? So it is really close to almost floating, right, because of the fat content, but then there's enough of other stuff going on that it would sink. Any fat is going to float on water, and so it would be a negative Hounsfield unit value. All of this is tying, it's just giving us a nice, neat way to talk about linear attenuation, because you start saying the word linear attenuation at parties and you really freak people out. So a 1% increase in attenuation equals about a 10% increase in the Hounsfield unit. It's really an accurate way of expressing this, and that's helpful for us as clinicians because the Hounsfield unit has that expression of sensitivity and specificity, which is the reason why CT is the gold standard for so many diagnostic procedures, right? Because of that incredible amount of specificity when it comes to expressing attenuation values. Things that will influence the Hounsfield units is kiloelectron voltage, so average beam energy is influential to the Hounsfield units. It can throw off the scale slightly, and so it's important when we're reading research or when we're thinking about this, looking really specifically at what the KVP values were that were used in different trials, and if we're using a CT scanner for any kind of cancer trials, the KVP is going to be very important because it can influence, again, what the Hounsfield units would be for the tumor that we're trying to assess, right? Another thing that would be impactful would be filtering of the X-ray beam, and it's the exact same process of increasing average beam energy. So something like a cupping artifact or a beam hardening artifact will throw off your Hounsfield units. We see this all the time at the base of the brain, where all the hard bones at the level of the temporal bones are causing this cupping artifact or beam hardening artifact, and it throws off the Hounsfield units for the brainstem. So here's just another expression of the Hounsfield scale, and this is a little bit more true to life. The other one I'm not a big fan of it because it's kind of got things backwards. What do I mean by that? Well, on this one, we've got water right at that 0 point, so there's water, right? As we go into the positive range, like positive 1,000, we've got what? We've got stuff like bone, right? Stuff even higher than that, because there's stuff that attenuates even better. The bone inside a patient's body is like a titanium hip implant would have an even higher Hounsfield value. It would be something that would literally be off the scale, like room air, negative 1,000, right? And so I indicated that lung tissue would be somewhere slightly higher than that, like negative 800. So this is that range of potential attenuation values zeroed off of water according to the Hounsfield formula. This is what I think we need to understand as CT technologists when we're sitting down to take the registry test. This is what we need to know in terms of clinically guiding studies and thinking critically about what we're trying to visualize. And we're going to see in a second a really, really hands-on way that it impacts our day-to-day work. And that is related to window settings. Because so all of this Hounsfield unit stuff, if you're totally lost at this point, I encourage you to go back over the lecture and really digest what I'm saying, because all of this is impactful to the window settings that we are looking at in CT. So this is the exact same patient, the exact same slice values, the exact same attenuation values, right, on these two images. All that changed was the window level setting. So all that changed is the way that I'm displaying it, and I'm displaying it based on what we're trying to see, right? So on the image on the left over here, we're trying to see the lung tissue. So we're going to, and we'll talk more about what we're going to do with window settings in a second. On this image over here, we're probably trying to evaluate the heart, maybe the pulmonary arteries, the aorta. We're trying to see that contrast value. Okay, so let's look at these a little bit more in depth. Let's look at this one first. This is what we call a lung window setting, right? So this is a lung window. And a couple of things that are helpful to understand about the lung window, right, is first off, we would guess what the window level is, right? Guess what? It's negative. Well, that makes sense, right? Because we're trying to see something that weighs less than water. I mentioned earlier about the lungs weighing less than water. So we've set the level at negative 400, right? Now, what are we trying to see in terms of contrast, right? The contrast that we're trying to appreciate is we're actually trying to reduce the amount of contrast in a high contrast structure, which is the lungs. The lungs are super high contrast, right? They have a high subject contrast between these small lung markings, the alveoli and things like that in the lungs, and all of the air that's in the lungs. So we're going to increase the window width significantly. We're going to set a window width of like 1,500, right? That's roughly what we would expect for a lung window. Again, the level is negative because the anatomy of interest is less than water in terms of attenuation values, and the window width is really, really freaking wide because we're trying to see something that has a high subject contrast, so we're using a wide window width in essence to reduce that subject contrast so that we can see what we're trying to see. So let's do a compare and contrast with this next image. We might call this an abdomen window level, or maybe a mediastinal. I'm going to just call it abdomen because they're roughly the same, right? And the window level here might be about 50, so just above water, right? Somewhere in the range of most soft tissue structures, like things like blood in the heart, which is what we're seeing a lot here, and contrast and things like that. And this window width now, I'm going to draw it, it's going to be more narrow, right? So I've drawn it. You'll look between these two slides. I've drawn a more narrow window width. So we said 50 was the level. The width in this case might be about 400, right? So what we're saying in essence here, when we set the window level, we're saying where on the Hounsfield scale do we want to center? And I've said we want to center at 50. And then how wide in either direction do we want to extend out our area of visualization? So at this point we've zeroed at 50, we've set a window level of 50, and the window width is 400. So that means that this extends down to what? Negative 150 to positive 250. Where did I get those numbers from? Well, I went 200 in this direction, right? And I went 200 in the negative direction as well to give me that width of Hounsfield values that I want to visualize. Now you'll notice the lungs are completely blacked out. Why is that the case on this image? Well, because the lung values are outside of the window width that I've set. So the anatomy of interest inside the lungs is completely obscured by this window level and width setting. This abdomen window level and width setting has completely obscured the alveoli and all the little tiny lung tissues and markings that we were looking at on the lung window level, right? Why? Because again, it's outside of the range, it's outside of the window width, right? One way to think about this might be to imagine you're living in a different house, right? And there's large windows in this house and small windows in the house. With the small windows, we're able to see very specific parts of the landscape, right? So we're able to evaluate just the little tiny hill across the way from our house, right? But with the really, really large window, we can kind of take in everything, right? But we can wind up obscuring some stuff. So that's a really simplified way of thinking about this. All right, the final thing that I was asked to discuss is spatial resolution, which is a big conversation in and of itself. So I'll put a link to this other video down in the comments. Definitely encourage you to check this one out. I'm addressing line pairs per millimeter. I'm addressing how the matrix influences spatial resolution. So I look at it both from the standpoint of imaging technology and also from the standpoint of image production and focal spot size and stuff like that. And there's a lot of considerations that go into spatial resolution from both those two different directions. So even though the conversation is primarily about X-ray, it ties directly into what we're talking about with CT. Thank you so much.